We need elevator music for Zoom, but that's a bad idea.
No, no. Yeah, that's why I'm saying that would be terrible. Absolutely terrible.
I'm just kidding. Okay, Adriana, should we go forward? And Lori, it's 12 o'clock.
Yes.
Lori?
Oh, are we on?
Yeah.
Excuse me. Welcome, everyone. It's 12 noon in California and 3 o'clock on the East Coast. So we'd like to start this event promptly. We've got a full agenda, and I think I want to leave enough time for questions at the end. Welcome to today's Fireside Chat with Dr. Nora Volkow, the director of the National Institutes on Drug Abuse. Today's event has two sessions. First, Dr. Volkow will be discussing NIDA's strategic opportunities and other topics. And the second session is going to be for brainstorming and flash talks from the 5 UC campuses. Today's event is sponsored by University of California, Irvine's Institute of Clinical and Translational Science and by UC Braid. Braid is the Biomedical Research Acceleration and Integration and Development Consortium. It consists of the 5 UC campuses that are CTSA awardees, and we are in our 11th year now, proud to say. Next slide. Our vision is to harness the power and the possibility of the UC system to accelerate research that optimizes health. And we do this through collaborations and partnerships. Together, we work with different stakeholders to identify best practices, reduce barriers, and leverage and create shared resources. And my hope is that this event will lead to more cross-campus fertilization. Finally, some housekeeping. We are going to be sticklers for time, so I apologize in advance if you're cut short. Please use the Q&A section below to enter your questions, and we'll try to get as many of them as we can by the end of the talk. And you will be receiving a brief evaluation at the end of the meeting. I thank you in advance for taking a minute to complete that. Okay, with that, I will pass the baton to Dr. Daniele Pimomelli from UC Irvine. He is a distinguished professor in anatomy and neurobiology in the School of Medicine there, among other things. And he's also the director of the NIDA-funded Center for the Study of Cannabis. Thank you.
Thank you, Lori. It is my distinct pleasure to introduce Dr. Nora Volkow, director of the National Institute on Drug Abuse. In my opinion, Dr. Volkow encapsulates the very spirit of the National Institutes of Health, an American institution that the entire world envies. She's an inspired scientist, a thoughtful and courageous leader, and a dedicated public servant. Over the past 20 years since I've first met her, I've been an avid reader of her elegant and innovative brain imaging work, which has shed important light on the mechanism of action of psychostimulants, cannabinoids, and other drugs of abuse. And even though I cannot say that I've read each and every one of her 792 published papers, I can share with you that right now, one of her studies is on my desk as key reading material for an article my lab is working on. I'm also an avid reader of her editorial work, which she regularly publishes in the country's top scientific and medical journals. And I cannot overestimate the importance of this work. Dr. Volkow's commentaries, reviews, and perspective articles show how closely she monitors not only scientific developments the world over, but also deeper and often hidden trends in public health as they pertain to substance use and substance use disorders. This is what an inspired leader does and what we need in these times. Like other authoritative figures at the NIH, who are perhaps more visible, Dr. Volkow never fails to offer us a compass to help us guide our work on the basic and translational science of substance use and substance use disorders. So please join me in welcoming her at our webinar and thanking her for her participation. Hello, Nora. It's good seeing you almost in person. How are you doing?
Very nice seeing you too, and thanks for that very nice introduction. everything's relative in life. So when you're asking me, how am I doing? I sort of said, relative to what and where and how. And so, yes.
I hear you. I hear
I'm
you.
better than 1 month ago, actually. I'm better than 10 days ago. But overall, of course, we're all being challenged, like we haven't been challenged in many ways by the COVID pandemic. So, but also at the same time, I think that it is a remarkable privilege to be right now in a position where you can help address these enormous challenges. And I see that again as a privilege. So that's why I say there are many, many positive things, but at the same time, I do realize how much suffering there is across the nation and of course across the globe. So that's
Very well said, Nora. So this is a webinar about the NIDA strategic priorities in the COVID-19 era. So I'd like to start off the webinar by asking you two, if I may, two interrelated questions. The first is rooted in the impact that the social isolation, specifically imposed by the COVID pandemic, has had on the US population. I'd like to start there. You have argued many times in the past that social isolation, life adversities are major risk factors for problematic drug use. So what I would like to ask you is, in your opinion, what are the impacts that these factors can have or are already having on drug use patterns, but also perhaps more importantly to us today as scientists, what is it that we can do? What is it that we need to learn through basic science and translational science to mitigate, alleviate this impact?
yeah, and I mean, and it is indeed one of the major stressors that we have, that one of social isolation, alongside, of course, the uncertainties of what is going to happen with this pandemic, while at the same time we're seeing the realities of the economic downturn for many people and loss of jobs. So all of those factors actually collide into creating an environmental situation that we know is likely to result in an increase in mental health disorders and use of substances as a means to escape that distress. One of the most powerful reinforcers that we have as human beings, and one that actually motivates and drives us all in very different ways, is the social reinforcers. And from when we're born up to when we die, the notion of having us the recognition that we're part of a group, that we're part of a purpose that will help others is, I think, a very powerful driver of what we do. And that is actually before the COVID pandemic had already been discussed as something that had already started to degrade in our society, and that Tim Casey had put forward as a concept of the deaths of despair, because he had noted that the life expectancy of Americans was going down in the United States, and as opposed to other areas of the world where the life expectancy was increasing. And I say this is several years before the COVID pandemic, and he addressed this along with Ann Casey, who's the co-author of the first papers documenting this, that it is the lack of mission and purpose that is driving these deaths of despair. Overdoses, suicide, cirrhosis from both alcoholism and morbid obesity. So we already were aware that the social structure was not driving healthy mental states, that it was already being very challenging by many people. And then this, of course, gets terribly, terribly confounded with COVID because of just the magnitude of what's happening in the country and in the world. We know already that alcohol use has increased significantly. And this is the best indicators that we have are with sales of alcohol, which have gone up abruptly during the whole period of COVID. But also we're seeing that in terms of the revenue that the states are getting from the marijuana that is being sold, and that actually indicates that those sales have increased also significantly across many of the states in the country. And these sales are being increasing, and reflects indeed that more people are taking drugs. In the meantime, there has been also a recognition and reported that there is an increase in anxiety, depression. And for us at NIDA, we've been monitoring very carefully what's happening with the opioid crisis, because it was actually out of control before COVID came. And the first worry that we had is how is COVID going to affect that already, that epidemic that had been already going on for 2 decades, which we had not controlled. And the data actually shows a very marked increase in overdose mortality from opioids, beyond what was already present before COVID. And we're also seeing too a shift in the pattern of drug taking, increasingly more and more towards synthetic drugs, predominantly very notable synthetic opioids, fentanyl, but also methamphetamine and drug combinations. So these, all of these elements are not in any way facilitated, but actually are exacerbated by that social isolation with many of its downstream effects. So I'm just highlighting on these major themes, while at the same time recognizing that the social isolation may have more slower, longer lasting, and not totally evident impact, particularly when we're speaking with children and adolescents, where the negative effects may not really been fully realized until later on as they grow up. So that's what I would say that is in my brain, what jumps as most salient about the question on social isolation and how it affects our risk for drug taking and mental health.
Yeah, that reminds me of work that comes out of the NIDA intramural program, showing that when rats are given the option between interacting with a conspecific, another rat they are used to, or take cocaine, they actually prefer the social interaction. So do you think that we as basic scientists, as translational scientists, should be spending more time or effort in understanding the social underpinnings of our addiction?
Absolutely. I think that it's one of those things sometimes that we don't see it as an important scientific question. And yet the impact of social interaction is so fundamental for the human brain, for the brain of many creatures. But for us, I mean, it's hypothesized that one of the reasons that we have such complex brain actually evolve as a means to understand and predict the complexity of interactions with other individuals. So it's fundamental in how it drives our brain. It's fundamental in our sense of well-being, including our mission. So understanding how and what are the processes that are responsible for the saliency of these reinforcers through social interactions, understanding how they impact our brain and our well-being through development and how they guide neurodevelopment. I think is an extraordinary area of science, and it's certainly starting to expand more and more as researchers identify, like the paper from Javin Shaham's lab that you're commenting on, how important it is in terms of driving drug taking. The lack of a social reinforcer drives drug taking. And on the other hand, a purposeful interaction, social interaction, provides resilience. And this has been recognized, I think, clinically, epidemiologically, but much less has been targeted towards understanding it from the basic neuroscience perspective. And I think it's a great opportunity. And as you're asking me, for example, in terms of the effects of addiction and just in jumping on it, the effects of opioids, I mean, certainly we do know opioids, one of the components that are relevant is when we remove the mu-opioid receptor knockout mice, those animals, those mothers do not rear their newborn, and their newborns don't recognize the bonding with the mother. So if you're generating tolerance to the mu-opioid receptor by taking drugs, one would predict that those processes are likely to be very markedly disrupted. So understanding that, in my view, for example, will be very relevant to do interventions to help mothers who are addicted to opioids, who maybe, whether they are on treatment or not with medications, to understand how that influences their interactions with their newborns or their children, and how can we strengthen the value and make those interactions more positive.
I think we forget at times, we live in such an individualistic society that we forget at times how social we are. I often tell my students or whoever wants to listen that I ask the question, so you don't know how social you are until you ask yourself the question, when is the last time I invented a new word? We we use the language that everyone else uses. We have the thoughts that everyone else has. And one famous psychoanalyst many years ago said that we don't have ideas, ideas have us. And I think that is true. Although I don't agree with that particular psychoanalyst, I think that is actually kind of true. And another system beyond society clearly is something that we ought to, social interactions and social rewards are really extremely important for drug addiction. One other area that I think has emerged with COVID-19 at the top of the agenda is the immune system. And this is also an area like social interactions that has been studied at the epidemiological level, but it's still, I think, understudied, although investigated, not enough, in my opinion, as it pertains to the use of drugs. So one thing that we will find ourselves with, when this whole mess of COVID-19 will be over, is a population where millions of people will have been infected, some symptomatically, some non-symptomatically, but in all of them, the immune system will have somehow changed, either the innate immune system or the adaptive immune system. So the question, and it's not a very articulate question, but the question that I have for you, Nora, is how do you think this will affect overall the public health problem linked to substance use, and also how should we incorporate that in our research agenda? What can we do? What experiments can we do? What lines of strategies do you think we should follow to address this knowledge gap?
I think that, it's an extremely important point, and I think my first recommendation is being very aware of it, and the type of research questions that one can go after can be quite varied. I've been very much intrigued by the notion, of course, that which I think is very important for us to keep an eye on, whether these infections affect the human brain. And as we know, there's been work that trying to understand if neurons are infected by COVID. And while there have been some positive results, overall, most of the postmortem brain studies have indicated that the infection itself actually appears to be quite rare. It does happen, the neurons can be infected. But on the other hand, what is not rare is the presence of neurological and psychiatric symptoms associated with COVID infection. So whether there is viral infection or not, that's not going to be the only way that the brain is going to be affected. And there are two very important mechanisms by which COVID, of course, can affect the brain. One of them is because of the vascular damage that it produces that can result, of course, in ischemia and necrosis of brain tissue and strokes, and can lead to disruption of the blood-brain barrier, which then opening it up allows for other neurotoxic substances to go in. And the other one is that immune response, inflammatory signals that are part of the response of our bodies to the virus in trying to defend it, and ultimately can also generate very severe consequences. We know more and more that the immune system modulates the function not just of glial cells and microglia, but also of neurons. And there is an increase in interest on the involvement of those inflammatory and neuroimmune responses on the brain diseases, not just the neurological ones, classical that we know of autoimmune diseases, but of diseases that we don't think so much as being neuroimmune, like schizophrenia, like depression. And more data does suggest that these, they do have dysregulation and that these inflammatory disruptions are relevant in the symptoms. Similarly with addiction. And in this case, what you have is the combination of COVID producing these changes, whether it is there is an infection or not. Let's leave that a little bit unresolved. But there is no question that there is these vascular changes, these immune responses, and in interaction with the drugs. And that the drugs have very diverse effects in immune function. And that perhaps the one that has been most investigated is the opioid system. But it's not the only one, of course, associated with immune responses. Alcohol that also has extensive investigation showing how disrupted it is to the immune system. And as you know, I mean, obviously, you are one of the leaders in the world on the cannabis system and how it regulates immune function. So how does it interact? And in all of this dialogue and narrative about the involvement of the immune function in the brain and the response of the brain to COVID, there is an area that I'm particularly anxious about, and that is the notion of potential effects in the fetal brain or on the brain of a child that gets infected. And I think the responsibility that we have to monitor whether indeed there are long-lasting changes associated with these viral or immune or vascular responses that can be deleterious to the development of the human brain, and that can make those children as they grow up more vulnerable to neuropsychiatric conditions. So that's another area that I think is going to be very important to investigate. But the field is so wide and there are so many unknowns that that's why I say that the type of research that one can do can vary very much in terms of the expertise and the specific questions that you're going after. And ultimately, I would hope with the opportunity to develop interventions to minimize the potential harmful effects of an abnormal immune response into the brain, and also to prevent them and to treat them if they do happen.
To your point, which is very well taken, of the potential prenatal effects of COVID-19 or SARS-CoV-2, there are actually substantial similarities between SARS-CoV-2 and Zika virus. And that is something that I was also very worried about. But I think there are other questions in the group, and I don't want to monopolize. I mean, I could go on like this, talking with Nora for hours, but if she had the time. But I'm sure there are other questions from the group.
Danielle, there's a question from Dr. Mukherjee at UC Irvine. Active smokers seem to be somewhat resistant to COVID. Do you have any thoughts on the role of nicotine in the COVID pandemic?
Yeah, and this has been a very controversial area because there have been some reports that show that people that were actually on nicotine when they got infected were less likely to get infected when they were exposed to get infected and have less severe symptoms. And that led a group in France to do randomized clinical trials using nicotine patch to investigate whether indeed nicotine may have some therapeutic benefits. On the other hand, if you look at epidemiological data from many other countries, including the United States, and we look at the very large electronic health records from patients in the United States who had a long history of smoking, to look at the risk of infection compared with the rest of the population, and to also look at their outcomes. And we saw a very significant increase in risk for infection on the one hand, but also a significant increase of risk of death if you get infected. And you can, and these things may not necessarily be contradictory, even though they sound contradictory, because what, I mean, the way that I see the high risk and the adverse effects of someone that's a chronic smoker is because the years and years and years of smoking have deteriorated their pulmonary and cardiovascular system, and those make them more vulnerable for infection, perhaps at a lower dose than that would have been required. And if they do get infected, they don't have the resilience to compensate for the damage and the disruption produced by COVID to the pulmonary epithelium. And independent of that, if you don't have a history of smoking, you do not have those harmful effects. Could it be possible that nicotine could have some therapeutic benefit? I mean, I do not know. That's why we do randomized clinical trials. But again, it's not, these are not contradictory possibilities. And clearly what is clear is that chronic smoking, chronic vaping is actually harmful. And to the extent that it is harmful, there have been a couple of states that have been priority for vaccination for individuals with a history of smoking because of their increased vulnerability.
There's a question from some of the developmental biologists. Dr. Volkow, NIDA was way ahead of the game in the ABCD project, which started a number of years ago. How are the data from that project, which is and I'm sure you'll be able to explain that to everybody, how is that project able to make some changes to address the issues that you've just raised about the developmental aspects of COVID and its impact on children and adolescents?
When they actually, the emergency call was made because of COVID in March, we immediately had a release for requests for supplements for researchers that were able to rapidly address scientific questions relevant to COVID, because we were in a new world. We didn't really know much. And we were particularly interested on how could we take advantage of the infrastructure that had been created from the ABCD, which is following close to 12,000 children, initially started at age 9 and 10, and now following them through, in terms of the opportunity to ensure that we will be monitoring, since we had the images of their brains for all of them prior to COVID, and for half of them, the repeated follow-up images were already present, and many of the behavioral assessments were basically, of the prospective assessments, were already completed. So we immediately started to supplement the ABCD to start with, to ensure that they would be tested for exposure to COVID, and to also have surveys, periodic surveys, to understand better how COVID was affecting the life of these children, adolescents. And they've actually already released the data, and the data is open access and in formats that are relatively easy to use, because we want researchers that are interested on asking these questions. How has COVID, for example, affected the life of families and adolescents, to be able to take advantage of it? So the data that we have right now, that we have supplemented through the ABCD, and that will be going on, has been specifically towards identifying through surveys and questionnaires, because it has been very difficult in many of the sites to actually see physically, which is what's required to do the imaging studies, or to obtain samples, blood samples or saliva samples, to see them in person. We hope that as some of these sites are starting to open, that data will become available. And again, this is open access. Anyone can take advantage of it. And the other thing that we did is we've been in the process of creating pilots in order to launch an equivalent to the ABCD, but starting in infancy, which is caused by the HBCD, for healing brain cognitive development, similar to the ABCD, but starting 3-6 months of age. And we had already given funds to 27 pilot studies across the United States, and some of them had started to image these infants before COVID, and we also supplemented them. And so now there are researchers that have images from infants who got the mother got infected when they were pregnant, and the child now has been undergone imaging. So we can, researchers are starting to compare their images with those that were obtained by children of the same age prior to COVID. So again, this offers an incredible infrastructure to start to address questions that we in the past would have not been able to do like this, because we've learned how to integrate efforts, how to harmonize protocols, how to image children, which can be sometimes a challenge because of motion artifacts. So this is I think a very powerful set of studies, the ABCD and the HBCD, to help us address the question that we were just discussing in terms of brain development. And also, I don't want to minimize neither their effects on how they interact with one another, their effects on things like spontaneous physical activity, sleep, understand better how COVID has affected those dynamics.
I have a methodological question that somebody emailed to me about this, and that is, what is the progress that we have made in accessing tissues that actually reflect brain development and brain function? Because you mentioned the immune system and you mentioned salivary markers and blood markers, but the difficulty that many pediatric researchers have is if we find an inflammatory marker, for example, in the saliva, which a lot of people are looking at, what do we need to advance the field so that we can use these more accessible tissues to gauge how the brain is developing and whether susceptibilities to drug abuse are becoming more real?
Yeah, and that is certainly a complex question, because obviously the brain is so complex that you say, well, what could be used as a model to study the effects on neurodevelopment? I mean, certainly, there is all of the work that goes on animal studies, and you can manipulate now with CRISPR technology, modify specific cells that you may be interested on studying. We are also very much interested, and we've had requests for proposals for this purpose, to use the pluripotential cells as a means to actually derive a cell that sort of a neuron or with specific characteristics out of blood cells, and then investigate there, for example, how drugs affect them on the basis, of course, doing it personalized. So if you have certain genes that may make you more vulnerable to drug taking, then you can use these cells and see if they respond differently or not. And two, I mean, an area that within that pluripotential cell investigation, as well as just looking at the question, can you use a blood cell, peripheral blood cell, as an indication of what may be happening in the brain, has been done using to see how the changes of epigenetics in blood cells correlate with the changes on epigenetics in the brain. And there are some areas where you can approximate some processes, but of course, this is limited by the fact that you are generated an extraordinary complex system into a model that aims to do it at a cell basis or on an organoid. So there's a lot of interest, and NIDA has had several grants requests for using organoids to study exactly processes like infections, hepatitis C, HIV, and now COVID in these organoid systems, and to separate, for example, effects on the blood-brain barrier versus neuronal and glial cells. So there are these more complex organoids that can include these different elements. So these are tools, and we need to evaluate them. I think they are promising, and they can guide us, but again, until the research is done and it shows us how it sheds light into new processes, it's at this point, I mean, I like to say these look very promising. I don't have anything specific or factual that I can illustrate how it has been used in a way that has advanced. I mean, it's still early on.
Here's a question that I think is really important. I mean, all of the questions have been, but given the disproportionate impact of the pandemic on minority populations, how will this work to impact the kinds of studies that NIDA and other parts of the NIH are developing? And how do you interpret the bias between COVID-19's disproportionate effects with some of the more basic science discoveries?
Yeah, and again, this too is a complex question, right? When we address the issue about the health disparities that have become so very evident with COVID, since the morbidity and mortality is so much greater in African Americans and in other underrepresented groups, but clearly in African Americans. So you look at it, and one of the factors that drives that higher levels of mortality from COVID relates to the fact that they have not received quality health care. And as a result of that, they have many more comorbid conditions than others. So when you address the question, well, from the perspective of neuroscience and neurobiology, how do you then address the notion of structural racism? And that is, I mean, I think that we should be thinking about it in terms of like doing what models one could use to try to understand these social hierarchical systems. And you mentioned I think Daniele mentioned the work of Javin Shaham, showing that social isolation is very negative, and social punishment, he didn't mention this, but they also show it's very, very negative. And there's also the work on rodents and also in primates by Michael Nader that shows that social hierarchical structure profoundly affects, in his case, he was studying the dopaminergic system signaling through the dopamine D2 receptors, which are crucial for self-regulation and for overcoming adverse responses. So, and he shows that being basically a subordinate on an environment with primates where it's very, very stressful leads to a downregulation of that system. And that has similar findings have been shown, of course, not with the elegance that you can do in a non-human primate, but have also been shown in humans, that social systems negatively impact the function of the dopaminergic system through the D2 receptor signaling. And now with the ABCD, what I found one of the most interesting findings, because again, the data is open access, so anyone can look at it. And what is clear is how negative is the impact of an adverse environment. And that one of the main factors that drive those adverse consequences of the environment is low incomes. And overall, of course, African Americans have much lower incomes. And you can account for the differences in brain development that you see between Caucasians and African Americans by the low income. So even at there was one of the first studies that came up in Nature Medicine, I think it was Nature Medicine by Morgan, that shows that the adverse effects of lead on the brain are basically modulated by your income state. So if you come from a low income, then you have a very profound negative effect of lead. But if you do not, then if you come from a high income, it doesn't matter. So it's almost like I look at it from the perspective of cancer, right? So you are not going to get cancer if you just have one insult. You accumulate insults, and then you actually start to see the cells becoming malignant. And I see this as if you come from an underrepresented group and from very early on, you're at a disadvantage and you suffer multiple insults as you're growing up. And that eventually destroys your resilience and makes you so much more vulnerable. And I think that is, again, in thinking about how can one study it from the neurobiological process, perhaps thinking it that way, like we've done with cancer, and understanding how how these cumulative effects negatively impact the way that the brain functions.
Yeah, you've anticipated a question from Dr. Tally Barham, who leads our Conti Center and is really an absolute pioneer researcher in the impact of early life adversity just on brain development in general. And just to be specific, her question is looking at early life adversity as a risk factor a priority of NIDA in terms of mechanisms and target development? I think you answered the question, but please comment on that.
Absolutely. And I think that why is it important? Why is it so important, I would say, is because the most powerful intervention that we have to address addiction long-term is prevention. And in order to do prevention, actually knowledge in terms of how to help modify or buffer or revert the changes from these insults is crucial. And to me, that's one of the reasons why both the ABCD and HBCD are such important studies, because by providing us knowledge on how adverse social environments influences the brain, by understanding what those effects are, we may then develop interventions and assess whether you can revert them or not. But you need to understand what they are, and you need to have a ways of measuring them and monitoring them in terms of, so you can see if the intervention is doing what you're saying it should be doing or not. One of the consistent findings with the ABCD, and again, it had been shown by prior studies with small sample sizes in terms of income and adverse socioeconomic factors, is that it actually results in smaller brain volumes that as well as thinner cortical thickness overall. I mean, in general terms, that's actually one of the adverse effects. So how do you then counteract that? What type of interventions you can do to modify and accelerate and revert those changes that may have happened? And because the brain is so plastic, and particularly during childhood and adolescence, it really behooves us to try to figure out how to do it.
I think we're going to have time for one more question, and then I'm going to turn it over to Dr. Wood in our next session. This is actually a question from Dr. Gola, who you will be hearing from. Social isolation moves a lot of interactions to the online space, which results in the increasing prevalence of gaming disorder and other behavioral addictions related to digital entertainment. Unlike substance abuse, the majority of teenagers and kids are not protected from the risk of behavioral addictions, and we know very little about behavioral addictions' impact on the developing brain. Does NIDA have any plans for addressing these problems?
Yeah, and indeed, there is a very detailed assessment of screen time as part of the ABCD study to try to exactly understand better what are the potential negative effects and how can we predict under what type of behavior is likely to have a harmful effect. And Dr. Paulos already had a paper showing that for children with extensive hours of screen time, they also show abnormal brain development, significantly abnormal brain development, and that hasn't yet gone into diagnosis of having a disorder of video game disorders or other types of web-based disorders driven by this virtual world. But it will, as the children transition into adolescence, we will start to see that emerging. And what we do know is, because as part of the supplementation of the ABCD, is that interestingly, in many of the households where there is a need, because the parents have to, the children are not at school, they have to stay at home, there is an increased surveillance by the parents of their children. So that has been sort of a finding, except in children that come from very low income families where the parents are not able, that they have to carry going to work despite the infection. In there you see the opposite. So yes, it's very important. We recognize that this in and of itself puts children and adolescents at risk, and that and I don't know how it will ultimately interact with drug taking. I mean, a lot of the video gaming is associated more with caffeine intake, with sugary drinks, with energy drinks. more so that from what we know right now than the consumption of drugs like marijuana. But then as these adolescents grow older, could this prime them? And we don't have answers.
Shall we move on, Lori?
Yes, let's move on. Thank you for that really engaging discussion. We'll roll over into the next session in which we're going to go to some researchers at each campus for a 2-minute flash talk of their work. And this will provide a sneak peek into what some of your UC colleagues are doing across campuses, and also hopefully what Dr. Volkow's appetite to see kind of the interesting work we're doing here. The session will be moderated by Dr. Marcelo Woods. Dr. Woods is the chair of the Department of Neurobiology and Behavior at Irvine. Take it away, Dr. Woods.
Hi. Okay, Nora, thank you very much for a wonderful discussion. We had a question in the Q&A that we didn't get to, but I'll bring that question back in this next section because it's relevant to one of the talks that we're going to hear about. So these 2-minute presentations will be very short, very brief. I will be timing them, and what we will all hear are current directions and opportunities in substance use and use disorders across 5 different campuses. And so our first speaker is Dr. Jennifer Whistler from UC Davis. Jennifer, all yours.
All right, next slide, please. So our study is founded on this seminal finding of Dr. Volkow's of a loss of D2 receptor availability in the striatum of all drug abusers of all kinds, right? And my lab has spent many years identifying the molecular mechanism that we think underlies this drug-induced loss of receptors. And if you go to the next slide, that is in conditions of high dopamine tone, you get a lot of endocytosis of the D2 receptor. And unlike the D1 receptor and the D5 receptor, the D2s and D3s are targeted for degradation in the lysosome through interaction with this GPCR-associated sorting protein called GASP. So as Dr. Volkow mentioned, we know that both things that like bad being part of the bottom of the pecking order can give you lower D2 receptors, but drugs can also drive loss of D2 receptors. So it's both a cause of drug use, but also an effect of drug use. And our program is designed to leverage across systems, next slide please, to address this at a whole bunch of different levels. So at the molecular level, we're asking, why do the receptors degrade, and are there ways that we can manipulate that? At the clinical side, can we restore D2 receptors using our knowledge of pharmacology and ligands, for example, that don't drive endocytosis of the D2? For the behavioral changes, again, looking at what are the things behaviorally that change when you lose your D2 receptors? And lastly, are there other drivers, including things like we've already discussed, like low position on social hierarchy or a poor early life experience that is going to drive down D2 receptor numbers. So if you click one more time, that in the molecular area, we've got 3 genes: the GASP gene that sorts the D2 receptor itself, and dysbindin, which we know has various levels in other neurological disorders that change the sorting of D2s. And the clinical side, we have genetic variants in all of those genes that are going to change those gene numbers, as well as drugs like Abilify that block degradation by blocking endocytosis of D2s. And for the behavioral changes, we're looking at many things there. So these are going to talk back and forth to each other. And for other drivers, we have researchers doing maternal immune activation, chronic stress and pain, and traumatic brain injury. And we have evidence that all 3 of these things alter D2 receptor number.
Terrific. Great. Thank you.
Mm-hmm.
All right. Our next speaker will be Dr. Steve Mahler from UC Irvine. Go ahead, Steve.
Thank you. So addiction is a complex and heterogeneous disorder, which is really something that I think we have to confront, as we have been talking about, if we hope to come up with better treatments. And as has been mentioned, it's ultimately can be conceived of as a developmental disorder in which there are factors that can convey predisposition, such as genetic or developmental experience factors, Things like adolescent drug use. So this is a vulnerable stage of brain development. And if you're using drugs at that period, it can have long-lasting effects, as well as the progression of the disease in adulthood in people who are chronically using drugs. All three of these phases, and probably many others, are impacted really importantly by adversity and stress. And all of this is filtered, it seems, through sex also. So in other words, if we're going to understand how addiction actually manifests and is predisposed in the brain, we have to look at all of these factors together, which is ultimately, I would argue, a question of basic neuroscience. We kind of need to go back to the basics and improve our rodent models, our preclinical models, and to maximize their translational relevance. So in order to understand addiction better. Basic neuroscience is a historic strength of UC Irvine, and our group here in terms of addiction neuroscience has been growing quite a bit in the last several years. And one thing that kind of unites us is that we're all really interested in how sex, age, and adversity impact the addiction process. And this is kind of a core theme of our Irvine Center for Addiction Neuroscience, which was recently awarded a T32. Thank you, Dr. Volkow. And also we have a NIDA P50 center looking at adolescent cannabis exposure and how that can impact brain development, including addiction vulnerability later in life. And some of us have been trying to also maximize the translational relevance of these sorts of models by using vapor exposure, for example, to nicotine and THC. We also have some other unique opportunities for synergy. So we heard a question from Dr. Barham. She runs an NIMH P50 Conti Center, which focuses on early life adversity and sex and how those impact brain development. We have some very recent exciting findings that are the subject of some current proposals that show that this conveys a really massive sex-dependent impact on opioid addiction vulnerability in particular. And then finally, I'll just point out that another strength of our campus is that we are really kind of trying to take some steps towards improving the next generation in terms of diversity. We are a Hispanic serving institution, as well as we're proud to say we are the home of Angeline Dukes, who's the founder of Black in Neuro, which is gotten a lot of attention lately as well. She's a graduate student in Dr. Christy Fowler's lab. And with that, thanks. Thank you for your attention.
Great, thank you. Angeline Dukes just had a very nice open letter commentary to mentors in Nature Neuroscience. Nature Reviews Neuroscience just came out, if anyone's interested. Okay, our next speaker is Dr. Steve Shopta from UCLA. Steve, go ahead.
Thanks. Next slide. So this slide here. My mission, hi Nora. My mission is to study treatment of substance use disorder, a problem nationally that has been endemic in the West since the 1990s. And I do this from 3 platforms. The Center for Behavioral and Addiction Medicine at the UCLA Department of Family Medicine conducts clinical services and teaching. The Center for HIV Identification, Prevention, and Treatment Services, CHIPS, is an NIMH P30 that I lead that promotes science networking and capacity building to address substance use, mental health, and social determinants comorbid with poor outcomes for HIV care and prevention. And then finally, NIDA's Clinical Trials Network, new big Southwest node in the CTN, where together with Madhukar Trivedi and Jennifer Potter, we have a paper in New England Journal of Medicine talking about the benefits of extended release naltrexone plus high dose bupropion for methamphetamine use disorder. It's the first report of a broadly effective medication for methamphetamine use disorder, period. So next slide. So what do we want to do next? We want to really bear down on this issue of methamphetamine use disorder, and one of the most exciting things that's come along in a long time is this clear scientific small molecule. It's a small molecule that doesn't cross the blood-brain barrier. It goes into blood, sequesters methamphetamine, and takes it to the kidney for excretion. There's no receptors in brain. It uses passive gradient, moves about 400 to 4,000 times more methamphetamine than placebo over an hour into urine. It also binds to fentanyl. I sound like a television commercial, but wait, there's more. It binds to fentanyl as well. So this is a real nice opportunity for a wonderful treatment for comorbid overdose. And then finally, just a shameless plug, we're doing CTN-0110, which is a methamphetamine injectable treatment for people who have opioid use disorder and are co-using opioids.
Terrific. Thank you very much. And absolutely on time. Thank you.
Yes, I hear that, but I can't stop because I'm old.
All right. Our next speaker is Dr. Matus Gola from UC San Diego. Matus.
Hello, it's a great pleasure to be here. I would like to bring to your attention an emerging topic of behavioral addictions, which have been recognized with the inclusion of gambling disorder in DSM-5. Next slide, please. And in 2019, World Health Organization went 2 steps further and included not only gambling, but also gaming and compulsive sexual behavior disorders into the upcoming ICD-11 classification. Our studies on adults uncover similarities in psychological and neural mechanisms underlying behavioral addictions and substance use disorders. Unfortunately, we still know very little. Insufficient knowledge to inform policies results in significantly higher prevalence of gaming disorder, problematic pornography, and social media use among teenagers than adults. Parents and educators struggle with numerous unanswered questions about the impact of digital entertainment on kids. Next slide, please. During the COVID epidemic, socially isolated teenagers and kids spent much more time with screens than ever before, which creates favorable conditions for the development of behavioral addictions. Researchers report the tremendous increase in problematic gaming and pornography use in 2020, and clinical psychologists alarm about potential consequences for the future. Therefore, there is a need for systematic research on behavioral addictions, especially among kids and teenagers, allowing to answer questions on how does the behavioral addiction predispose the substance use disorders or other comorbid disorders in older age. What are the main vulnerabilities for behavioral addiction? And is there any critical age for development? What are the most effective ways for early prevention? Or what are the details of neuronal mechanisms and effective methods of treatment? This is the time to take a closer look at behavioral addictions and include them in the research agenda. Here at UC, we have extensive experience with ABCD study, and we are eager to run a program tackling more detailed questions on behavioral addictions, for example, as a further supplement for ABCD. A better understanding of this rapidly emerging clinical issue is of high interest for us and for the future generations. So that's what we are doing and what we will be eager to continue studying to better understand how behavioral addictions affect the developing brain. Thank you.
Wonderful. Thank you, Matus. All right. So at this point, Nora, I thought we could start with, if you wouldn't mind, I know you're working on this NIDA strategic plan, the overall NIDA strategic plan for from 2001 through 2021 through 2025. And I was wondering if you could give us a snapshot of what is being considered in the overall NIDA strategic plan in a few minutes, and then discuss intersections with the presentations that you've heard here, and obviously any questions you might have for the speakers. We'll start there, and then we'll go forward. Oh, sorry, I missed one.
Yes, as I say, my God.
Yeah, sorry, Mark. Sorry. Our final speaker is Dr. Mark Schumacher from University of California, San Francisco. Mark, sincere apologies. Got ahead of myself.
No problem. Hi, Mark Schumacher here, the best for last, as it were. I have a talk that's slightly different in that it's a pitch a little bit. I'm a professor in chief of the pain medicine division. I'm a clinician scientist, but I'm also a director of an effort to launch a pain and addiction research center at UCSF. Next slide. And so what we're trying to do here is establish a transdisciplinary center that goes across all 6 professional schools at UCSF to essentially develop a model similar to the Cancer Center, where scientific discovery and investigation then informs practice. Of course, the rationale that's been discussed throughout this meeting is that, in fact, there are many aspects that are intertwined with addiction and drug abuse. And pain is a tremendous driver. And in fact, the effort behind this is really what is UCSF's answer to the opioid epidemic. And so we believe that we need to collaborate and combine our resources together. The design of this effort involves top to bottom and bottom to top coordination. It also involves integration in our UCSF health system and led by a core leadership team that's transdisciplinary. The key part I'll finish with is, of course, beyond sponsoring seminars and meetings, which are ongoing, we really are focusing down on thematic areas as shown in the bottom right. And that is, we really intend to pick some of the most impactful areas. And as discussed previously, we've started actually in terms of how to reduce disparities in both pain and addiction, improve education, and implement changes in our practices, including a focus on buprenorphine, both basic and clinical. So we hope that NIDA and other institutes would help fund us in a broad sort of way for these types of institute, and also provide this as a model. Thank you.
Great, thank you, Mark, and my apologies once again. Back to what I was saying, Nora, would you mind giving us a brief overview of what's being thought for the overall NIDA strategic plan and how some of those aspects might intersect with the things that you've just heard in these presentations? And then, of course, if you have any questions for the speakers, fire away. And then I'll draw questions from the Q&A. We already have one, and I'll integrate those into the discussion.
Yeah, no, certainly. I'm happy to jump into our strategic plan. And by the way, there are two strategic plans, the overall global strategic plan, but due to the really devastating disparities that COVID was pushing into, making us aware, my perspective was we really needed to focus on what is it that we can do towards addressing these issues. And so we did, in parallel, have been working on a strategic plan to address disparities and to diversify the working force. But let me speak about what is the strategic plan in general for NIDA, because one can make the argument that the strategic plan for diversity will be part, of course, of our major strategic plan. And like the prior ones, the issue is how do we advance knowledge in a way that prevents and substance use disorders and help us actually treat them. But how does one achieve, how can we, NIDA as an institute, facilitate and accelerate the development of knowledge? Because ultimately we do that by identifying the most talented scientists and providing them the resources to do that. So that's one of the things that we do. The other thing that we do very proactively is, are there opportunities that principal investigators may not realize that by integrating some of those efforts, we may maximize the output from actually, there may be a synergistic effect from all of this work together. And those are, and then the third thing that NIDA has to do, is this general concept of the strategic plan is identified where are there areas of scientific opportunities where actually an investment in science will yield you a much greater bang for the buck than others. And that, I think that areas, for example, like the BRAIN initiative that has brought about extraordinary ways of imaging the brain of rodents, or classifying cells, or characterizing transcription patterns in diverse group of neurons. All of those things are examples about extraordinary opportunities for scientific movement. But also we need to be responsive to urgent needs, and we cannot ignore them. And we have been actually challenged on the one hand with the opioid crisis, which is becoming more and more intertwined with a combination of opioids with psychostimulants. And that's something that we need to prioritize, because it is estimated that if there are no changes to the current, what's currently happening in the United States with the opioid crisis, well, since the year has already ended, there may be up to 90,000 deaths throughout 2020. So, which is, again, would be close to 30% increases in mortality if things don't change up to the numbers that the CDC recorded in June of 2020. So we need to address that. Another big challenge that we need to address and we cannot neglect is the legalization of marijuana across the country has resulted in a significant increase in the use of marijuana, particularly among young people and adults of all ages. And we've started to see, unfortunately, an increase in the use of regular marijuana among teenagers, which had been stable, and now it has significantly increased. And this has been facilitated, of course, these changes in policies and access to marijuana products of higher THC content. But another element that has accelerated it further has been the vaping of electronic cigarettes, which has brought nicotine into a forefront of drugs among teenagers, which had actually no longer been the case for combustible cigarettes because prevention interventions had shown enormous advances. But with nicotine vaping, 20% of teenagers in school on 12th graders will have reported vaping nicotine. And similarly, you know, with actually it's 25% for 12th graders. It's the same thing with THC. The more and more teenagers are using vaping for vaping cannabis, and that results when you are vaping, you actually can concentrate much higher doses, whether it's nicotine or THC. And so the escalation of drug taking occurs much more rapidly, and the adverse effects also occur more frequently. So here we have three major things changing that are urgent: opioid crisis, lots of people dying, the increased use of cannabis, which we are already seeing the negative medical consequences, and the fear that this may actually affect addiction and other mental illnesses, and then the concept of losing the battle against cigarettes just because people are coming through vaping and then they transfer into combustible tobacco. So we need to address issues of scientific opportunities while also address urgencies. So it's in that context that we have to write our strategic plan to recognize that we have to maximize these two components of what we do. So within that context, what are the things that we're going to be highlighting that were not a major highlight of our prior strategic plan? And I would say one of the areas that is fundamental is data science. And this has to do with the fact that data science has just exploded, and the modeling and machine learning and artificial intelligence projects that are going on have clearly already documented and shown us how powerful they are as predictors of what may be causing the pathology, as predictor of clinical outcomes, as predictors of what may be good therapeutic interventions based on data that is being collected. So we want to ensure, so we highlight in our strategic plan the importance of generating quality databases that can be used by the community to actually exploit it towards understanding better issues that are of relevance to substance use disorders. And that's actually quite broad. And that includes, of course, brain development. But also to ensure that the new scientific generation is trained on these methods and is trained on how to take advantage of these open access databases. So we are highlighting very prominently data science. Another area that we are very explicitly highlighting, which we have not done in the past, is that of translational science and innovation. We have always, and of course we continue to be, I mean, science, knowledge is valuable in and of itself, because you really don't know how knowledge will help you in the future and how it will be applied for solutions. But at the same time, we all come to realize that we've missed opportunities where if we had been more aggressive, we may have been able to move findings closer to a clinical application. So we've started on a program, a translation division at the Institute, specifically targeted towards helping advance this. And among the things that it has been doing is providing training on researchers on, for example, how to take an idea and bring it into a fruition for a product. So, and exploiting and using the challenge mechanisms and the prices in order to generate completely different ideas from what we have worked in the past. So the issue of data science and with all its components, the issue of translation and innovation. And then the other aspect that we have not explicitly addressed and that we're now doing is the importance of creating the strategic plan with input from those affected by the disease, people that are addicted to drugs. And we've actually already started by creating and partnering with the FDA to generate patient-derived outcomes that are meaningful to them, that could be used as potential outcomes that the FDA would recognize for an indication for a substance use disorder. For example, in the case of individuals with opioid use disorders, we brought them together and asked them that question. And then we averaged out what was the most frequent reason why people were saying they relapse and what would be most helpful for them to help them achieve recovery. And number one was depression. I mean, so they stated that actually interventions that would help them address depression will protect them from relapsing. And number two was insomnia. They cannot fall asleep. And this was almost as frequently cited as it was for depression. And yet in the past, per se, we haven't seen these as outcomes that we should be going after. And the third outcome is, of course, craving, which it has been in our radar all along. But what it does follow in terms of the line of thinking that we have right now in medication development, which is basically also delineated for the strategic plan, is that we are seeking for therapeutic interventions that go after these alternative outcomes as opposed to just go for abstinence and negative urines. And we have been having discussions with FDA to try to figure out what they need in order for them to approve these alternative outcomes. But that's something that we're extremely interested on solidifying because it will. I predict that in many instances, we may have mixed signals of medications that may have been valuable, but they just didn't lead to abstinence. And yet reduction in drug use could be incredibly valuable, therapeutically valuable, even if it's not completely clean urines. And I think that recognition of changing our perspectives. And then I'm just going to reiterate, because I say it's a different strategic plan, but it will be part of this. There will be a direct linkage, is the issue of how do we diversify the training, the research workforce? How do we address on the health disparities? And how do we start to do research using the neuroscience, the tools that we get from genetics, from epigenetics, from the brain, to understand how stigma negatively impacts the brain? How can you overcome it? And that is, again, to go beyond the traditional way that we think and just challenge ourselves. And you were all challenging me with the questions: how do you do it? How do you study this? And I think that this is an aspect that we would like to promote. And while all along recognizing that an area that we cannot lose track of is the training of the new generation of scientists. And now, in particular, with COVID and the fact that the universities have lost resources, that many of the universities have stopped hiring, and that with social distancing, it has been very, very difficult for young trainees, for scientists in the early stage of their careers to be able to advance them. So, but if we don't keep eye on the trainers, we won't have the science that's needed for the future. So this is what I would say is highlights in terms of the strategic plan and how it differs from the one that we had before.
It's fantastic. Thank you so much. It was very insightful, fearless, and pushing the boundaries as always. So at this point, I can either draw some questions that we have for you, or I wanted to give you a chance to, if you had any comments or questions for the speakers. I saw you taking notes, and I just wanted to give you that opportunity just in case.
Yeah, because I love them all. And yes, I do have a lot of questions. And I thought it's actually, I have to select what the questions have. One of the, basically, I cannot stop my brain because it made tremendous curiosity. In the presentation of Steve, where he's speaking about CS1103 that actually can be used to sequester methamphetamine or fentanyl. My question was, is this an intervention that would be seen as an acute intervention? And how does it work? I mean, what is the type of specificity? And what are potential toxic effects? Is there, how close is it to going into humans?
Well, you're gonna, thank you very much for the question, because your group actually put the Clear Scientific team together with our team, and we're preparing the FDA submission to get moving into the field. So we plan to do phase 1A within the next year at least. So we are super excited. This is a small molecule that is apparently, according to these folks, has very few side effects. It doesn't affect diet. It doesn't affect sleep. It doesn't do anything bad. All it does is it goes into blood using passive gradient. It's shaped like a C. It catches the molecule and takes it to the kidney. So that's all it does. It completely is out of the body in 10 minutes or in an hour. So, and it's in non-human primates, what happens is if you super narcotize the primates, what will happen is you can reverse that with naloxone, but the naloxone will wear off and then the animal gets re-narcotized. This actually removes all of the fentanyl from the body for these primates, and they walk away as if nothing ever happened. So this, I think, actually is going to revolutionize treatment for methamphetamine use disorder. Obviously, it'll be great in the emergency department, but I'm thinking a small molecule in long-acting injectable status will give people the ability to agree to come into treatment, have a relapse, and have nothing happen and not have to start completely over at day one, having gone through all of the awful stuff that happens when people relapse and return to treatment. So it's an advancement over naloxone as an opioid antagonist. This is not, it doesn't go to neurons. It doesn't do anything in brain. It doesn't fight with neurotransmitters. It's just a sequestering agent. And so the idea of co-formulating, once this gets in the field, co-formulating with, say, anti-HIV medications to be an HIV prevention drug, an HIV treatment drug that can actually help people who are perpetually viremic to maintain their viral suppression. There's just all kinds of ways that we're talking with the Clear Scientific folks to see how we move this forward. So we're not getting ahead of our skis. But we are really, this is my next 5 years for sure, so.
No, it sounds very exciting. And I think that I was thinking about it in terms of acute, but from what you're stating is that you also foresee it as a potential chronic treatment. And that is, which would be, again, a game changer.
Totally. That's where we want to revolutionize treatment so that so we bring methamphetamine treatment into primary care. That's my goal. Treat it just like diabetes.
Yeah, no, that's why I say I actually could not stop myself from saying it. I also I mean, I love all of the projects, and I think that all of them are very important. I'm just going to jump into the one from Mark, because the issue of creating a joint pain addiction center to help accelerate research is very meaningful. And I think that we have traditionally, the way that we've done science is just by having these silos, and we miss opportunities that actually are in a way artificial, because the comorbidity of these two is so large, and the molecular process actually have significant overlap. And hence, I think that bringing them together is a paradigm that may provide unique answers. So, I mean, my question is that how will this be a predominantly clinical center, or was it going to have a preclinical component?
Right, right. So can you hear me okay?
Very well.
Okay, so this is exactly the question, is to actually bring, I don't know of an even number, but adequate representation from clinicians and the basic scientists together. This is very unique. And so the working groups are a mix of both clinicians and bench scientists or translational scientists. And so beyond wanting to do sort of big things, we decided to move forward just with what's in front of us, and that is the use of buprenorphine, for example. And so we have both clinicians and addiction medicine folks, as well as bench scientists that do drug discovery and different computational analysis, so we can both understand how to improve on the science of that, as well as potentially come up with new formulations and ways to then bring that back to the patient quickly. So that's just one example.
Yeah, no, and I think that, I mean, obviously, one of the things that the Hill was trying to do was to integrate those two fields, but very much the research actually groups are quite separated. And I think this would be a very, very novel concept. So I look forward to hearing more about it.
Absolutely. If I could just add that, you know, we first tried to take this from a purely clinical direction, and it was way too complicated. So we went back into the academic research communities and got a consensus, and then brought that back towards the clinicians, and that's successful.
Yeah, no, it is. I'm glad you're all doing it. And I also, I mean, I guess I tell you, I was actually cannot resist myself, but in the presentation of Jennifer, when she's actually going after strategies to interfere and block the internalization of the dopamine D2 receptors. And did I hear you correctly that abilify may be a possible intervention to prevent degradation of the D2 receptor? And if so, how does it do it?
Yeah, so that is, you did hear correctly. And it is a high affinity, what we would call biased agonist. So it has very high affinity for D2s, much higher than dopamine, about 500-fold. So when it's in the body, it easily outcompetes dopamine for the receptor. And it supports G protein signal transduction. So the things that you need D2 to do for you to control your neuronal excitability, for example, but it doesn't promote arrestin recruitment and endocytosis. So we've basically shown, at least in preclinical models, that we can restore D2 number that's caused by loss of D2s because of drugs with 7 days of treatment with Abilify. So our hope is here now to translate that into non-human primates, and then hopefully into humans as well, because this is one of the few places where we can actually longitudinally say, let's bring in a whole bunch of heavy social drinkers, for example, since they'll be easy to track, and there's lots of those on a college campus, and they're easier than relatively easy to recruit populations like that. Keep a diary. We'll do a PET scan. We'll put you on Abilify or vehicle. When you enter the study, you get a PET scan, you keep a diary, and at the end we do another PET scan, and we say, does your progress in controlling your drinking, number of drinking days, number of high drinking days, for example, correlate with our ability to restore D2 number? And people have used Abilify before. That's why we've had trouble getting funding to actually do this, but not successfully. But I think part of that is because they haven't actually looked for the molecular correlate of what we're hoping Abilify will do. And it's probably going to do that better in some patients than others, depending on why you have fewer D2 receptors. Because as we've talked about, you could be predisposed to low D2 because of genetics. But if you're lost D2s because of drugs, we think we should be able to restore that. And so if you're not separating and correlating the actual restoration of D2 number with clinical outcome, you're missing the signal in all of the noise.
Yeah, no, and I mean, it's fascinating. And that leads me to jump into the presentation of Stephen, because he actually addressing the issue of adversity. And certainly we do know that stressors, social stressors actually lead to downregulation of D2 receptors, at least in rodents, non-human primates, and apparently it's also in humans.
Yep.
So my question then to Steve, I mean, how do you target this from the perspective of more, I mean, an intervention that prevents, once you have the adversity effects in your life, because nobody chooses to be born in an adverse environment, and so then you go on, and then these changes have happened in your brain. So how do you go about doing interventions to buffer them?
Yeah, well, I'd argue that we really need to know more about what these adversity-induced changes are and how they may differ by sex, for example, which we see some evidence is the case in dramatic ways, both in terms of circuit wiring and in terms of transcriptional changes and things like that, as well as how they interact with drugs once they're actually on board. After all, my sense of it is that, most people use drugs of one kind or another, and only some get addicted, and there may be a variety of reasons for that. And so, one of the ways to answer your question is to try to identify what are the unique and interactive influences of adversity with drugs and sex and age and all the other factors that seem to matter, in order to try to then, use that mechanism to develop interventions.
Yeah, no, and I agree. And then my last question goes to Golub, because I think that his presentation is about the new world where reinforcers are no longer drugs, but where you have actually these extraordinary reinforcing games and that actually can engage and that actually are developed in your brain to maximize the activation of the reinforcement system. So it's in a way like drug does it, but through our behavior. So where are you taking this? Do you have plans for creating animal models for investigating these reinforcers through behavioral interventions of unexpected rewards?
There are behavioral models for gambling disorder, but it's very difficult to create behavioral models for gaming or for compulsive sexual behaviors. What we show in our fMRI studies is that a lot of this persistency is related to the occupation of different subsections of orbitofrontal cortex, which is very unique for humans. And it's very difficult for this reason, for example, to create animal models, because some of those reinforcements are secondary order rewards, like points, things you learn the value of them while playing the game or while repeating some certain behavior. So it's a big challenge. Right now, we try to understand it better looking at adults. It's still very difficult to move this research to children and teenagers. One of the big difficulties related to lack of the funding mechanisms for this type of research. And another things are related to ethical issues. For example, problematic pornography use, which we can study among adults. It's very difficult to study it among teenagers because officially those materials are legal from the age of 18. But we already know from our studies that the average onset of pornography use right now in US, it's 9.5 years old. But it's hard to really do the research on this population. There's also a lot of taboo around this particular behavior. With computer games, it's easier. So right now we are still trying to figure out how to develop this line of research and if animal models are possible.
Yeah, no, and I was thinking it in terms because we do get grants that go for gambling, and it's an issue. Whether should this go to NIMH and to us, and ultimately it relates to where the resources are. And one of the things that I basically try to recommend the investigators is to link it with processes that, if you are able to link it with processes that are relevant to drug paralleling drugs, then it's much easier for us to justify funding it. And it actually also is useful because you can learn from one model to the other. And for example, one of the things that I've been very intrigued on all of these the issues of the reinforcement and the sensitivity of the brain to reward is the effects of sleep deprivation on the reinforcing system. And one of the things that has been characterized in these teenagers that engage in compulsive gambling or video gaming is that they are sleep deprived. And that is also what you see with drugs. And so this is an example about how you could link understanding one and then understanding the other.
Mm-hmm. Yeah, this is a very valuable suggestion. Thank you so much for that. Also, the sleep deprivation works both ways. It's like a closed feedback loop because or vicious circle, because very often, you know, that the screen time, especially on the computers where there are no filters for the blue light, also disrupts the sleep patterns severely, and they have more.
We're at the end of our time. Marcelo, did you want to?
Yeah, I was trying to jump in and say the exact same thing.
Okay.
Marcelo, you should have not asked me to ask questions, okay?
No.
Yeah,
So first of all, I want to thank everybody. I didn't have a chance to put in my own myopic focus on physical activity and its importance, though I know, Dr. Volkow, that you're very interested in that. And it seems like we've covered in this discussion about drug abuse the key elements of the social, biological, and behavioral ecosystem that we need for healthy growth and development. And we didn't talk too much about it, but for healthy aging as well. And obviously the COVID pandemic has really brought this into focus. And, you know, I'll just quote from a conference that I was on last week with Janet Woodcock, Rob Califf, and Martin Landry about the clinical studies that have been done in response to COVID. And only about, in the United States, 5% have been powered sufficiently enough to give us decent information. And I know that as we all move forward, we've really got to think about the translation. So I really want to thank all of our participants. This was an absolutely delightful session. And we look forward to working with you. Marcelo said that you were writing notes. I think you were writing checks for the UC system. At least that's what I hope will come of this. We were supposed to have you here in person about a year and a half ago. We're going to try to get you again, Dr. Volkow. If you would like to just finish with some hopeful thoughts as we move forward, I think that would be a great end for this wonderful session.
Yeah, no, first of all, thanks for having me. It's been a lot of fun, and it gives me an insight on some of the things that you're doing. I mean, certainly it's limited time, but if I mean, when I go there, it will give me an opportunity to also meet the trainees and hear the questions. And so I do look forward for that future invitation. But I do, in terms of hopeful, it's very, very easy immediately. I think that, I mean, despite all of the horrific devastation, we also have to realize that right now, I've never seen a period in human history, I think, where it has not been more evident than ever the value of science. I mean, it is just like clear cut, crystal, black and white. The solution for the pandemic is brought through science. It's the vaccines that are actually going to be able to control it and regulate it. And it is scientific knowledge that is able to provide us with these solutions. So, and I think that overall, because of course we've been living in a country that has been so divided, but despite these divisions and despite a denial of truth in many instances, science, it has not been able to negate how extraordinary important science is. And I think that we need to take advantage of that opportunity to continue that recognition and use it in order that the resources are placed so that we can train the next generation, that we have the resources to continue doing the work. I mean, one of the things that I am concerned about, and I hope it's just a concern and that it is so, is that with all of the economic downturn and the limited resources, that then you start to actually cut on the budgets for science. And that would be devastating. So my perspective right now is we have to all of us be ambassadors for discussing how incredible science is. And so that and communicating it in ways that I think are meaningful. I think obviously I'm not naive to realize that in addition to science, you need to have the humanitarian component that will put the resources to bring that knowledge to everyone in an equitative way. And so I think that also us as scientists do have and can play a very important role in making the knowledge equitable so it can benefit everyone. And I think that's the message with which I want to end up this really very interesting panel discussion, guys.
Thanks, everybody. And don't forget to fill out your forms. And thank you, Lori and David and Adriana, Marcelo and Daniela for wonderful moderation. Take care, everybody. Stay healthy.
Thank you so much.
Thank you.
Thanks a lot, guys, and be
Bye.
good. Be good and stay healthy.
Okay.
Again, Nora, thank you.
Bye-bye.